Welcome everyone to today's Globe Op Talk, What's the Best Case Scenario? Featuring Harvard University's T.H. Chan School of Public Health professor, Marc Lipsitch, and Boston Globe's editorial page editor, Bina Venkataraman. I'm Chris Avello, the Globe's Director of Subscriber Experience, and I'll be moderating today's talk. Before we begin, some quick housekeeping. All attendees' microphones are muted, and your video won't be displayed to anyone at any point during the talk. At the end of Marc and Bina's conversation, we'll take a few questions from audience members that have been submitted in advance or during the conversation. So if you have any questions that come to mind along the way, you can use the Q&A button in Zoom to submit them. This event is being recorded and will be made available to Globe readers following today's live stream. Thank you all so much for joining us. Bina, take it away.
Thanks so much, Chris, and thanks so much to everyone for joining us and for being some of our first audience for a series we're launching called Globe Op Talks. This is one of the very first. And the idea behind these talks is to really bring to you some of the world-class thinkers who write for Globe Opinion and Globe Ideas, as well as some of the unique voices we feature. And we're so lucky today to have Dr. Marc Lipsitch with us, who is the professor of epidemiology at the Harvard T.H. Chan School of Public Health. He's also the director of the Center for Communicable Disease. And really a world-class researcher, thinker, epidemiologist, writing and thinking about the COVID-19 pandemic. So thank you, Marc, so much for taking the time to be with us. The title of this talk, chat, conversation, is What's the Best Case Scenario? But I want to start a step further back from that. You and your colleague, Jonathan Grad, have offered this really useful metaphor for thinking about where we are right now with the crisis and with the pandemic as it's emerged. So you talk about the pandemic itself and the crisis as a storm, and all of us right now, particularly in the US, as having capsized, our boat has capsized, and we're now on a life raft. And the life raft is the metaphor for the current interventions like social distancing that we're using right now to address this. But you also are casting our eyes to the shore and say that where we need to get is to safe land, to dry land, which in your calculation estimation is widespread immunity in the population to this disease, COVID-19. So before we get to the best case scenario, can you walk us through, tell us what are the scenarios for getting from this life raft, where we are now, to getting to dry land?
Thanks, Bina, and thanks to everyone for listening. Yeah, so I think the crucial idea, as you said, is that for us to no longer be subject to this virus and its intensive spread, we need to get to a point where there is enough immunity in the population so that individual cases don't transmit to more than one additional individual case, and so the number of cases goes down instead of up consistently. And so if we say have an imported case from another place, that doesn't lead to a big outbreak. And similarly, if we have pockets of people who are still susceptible, they're few enough that they don't lead to large outbreaks. So that's where we need to get to. And at the moment, the only two options for doing that are getting a vaccine, which is effective and can immunize large fractions of the population, or some combination of vaccination and getting enough people infected so that there's immunity in the population through natural infection. Obviously, a vaccine is the desirable, but at the moment unavailable option. And so the scenarios for getting to immunity are, first, that we accelerate vaccine testing and production as much as possible, and I think that's essential whatever else we're doing.
But about how fast at sort of best could we do that? How quickly could we have a vaccine, even if we were going flat out?
Well, the estimates that experts have been giving up till now are about 12 to 18 months, and that was started about 2 months ago, so maybe it's 10 to 16 months, but these are all approximate. There's a lot of interest, and as you know, Bill Gates announced a plan to fund manufacturing simultaneously of many candidate vaccines, some of which may not pan out, but just in order to have supplies. And there are other efforts underway that may find ways to speed that timeline up through kind of extraordinary efforts, and I'm very supportive of that effort, because even with all these efforts, what we have to have is a vaccine that actually works, and we've never had such a vaccine. So it's partly a scientific challenge and partly a manufacturing challenge. So
Sure,
it's hard
sorry,
to say,
directed
but let's speed it up as much as we can. Then the challenge for getting to immunity through natural infections is first that for every 100 infections we have, there's going to be a small number of them that are quite severe, and one or two that might be, well, we don't know exactly, but for every 1,000, there are going to be several that are also fatal. So building up herd immunity is a costly, in the most fundamental sense of costing human lives. And we haven't figured out a way to get around that. Accelerating treatments would be the other piece. But given what we have now, we have to get enough people immune in the population, and we want to do that in such a way that we don't overwhelm our healthcare system in the process. And so to change metaphors a little bit, you can think of it as letting the air out of a balloon slowly or quickly. If you do it too quickly, the balloon flies everywhere and bangs into things. If you do it slowly, then ideally that is a more orderly process, and you have few enough cases at any one moment that you don't overwhelm the healthcare system. To push that metaphor further, of course, it takes longer to let the air out of a balloon slowly, and so that's why the more effective we are with social distancing and other control measures, the longer it will take. So it's a really hard dilemma, and I should say that although we've proposed some ways to manage that dilemma, Jonathan and I and other colleagues are not saying that we think these are the best ideas, just maybe that there aren't a lot of other great ideas. And we would really like to spur people to think of innovative ways to do this. Some of those include, I mean, we can talk about what some of those include maybe later.
Yeah, let's get there in a second. But to what extent, what can we learn looking around the world, looking at, for example, the contrast between what happened in Wuhan, where there wasn't early action, and what happened in other areas of China, what's happened in Singapore and South Korea, what's happened in Italy and here. I mean, is part of the reason that we don't have good options right now that we didn't act at a good time to begin with? What do we know from looking at those other examples about why we are where we are right now in the US?
Yeah, so I think what we know from those other examples is that Wuhan indeed was late to act relative to their epidemic. So they were the origin. And so when they acted, it was early in the calendar year. It was at January 23rd, but it was late in their epidemic because it had been going for a while. And what we see from the data from Wuhan is that about a month after they started to very intensely social distance, they finally had the peak of demand for intensive care at a level that's really unsustainable for them and for us by comparison. And some of our research has made that comparison. But other cities in China, which intervened on the same day, were earlier on in their epidemic because the epidemic hadn't taken off as much, and they did much better. So the comparator in our study with Ruan Li and colleagues is Guangzhou, a city where there had only been a handful of known cases by the time they shut the city down, and they never got anywhere close to overwhelming their intensive care capacity because they shut it down early. But the problem is that that's all sort of variations on when you grab the life raft and how wet you are when you've grabbed it. There's still every place in China and Singapore, which has followed a different strategy that I'll mention in a minute. All of them are still at this early stage of having most of their population still susceptible and still having to figure out some way to get from here to the endpoint. So I think there's success in the early phase, and then there's success in the whole pandemic. And what China did of just locking down very tightly was one approach. What Singapore did of not doing that so intensely, but very, very good contact tracing of individual cases and follow-up worked for a while, but now has sort of slipped out of their grasp because there are just too many cases and it's too hard to follow every single case. And Singapore is probably better at that than any other country in the world. So there are different approaches, and I think we can learn something from them. I'm a little concerned about the recent trend by some analysts to say that we need to follow the extreme example of China and implement involuntary quarantine outside the home, or even isolation of cases outside the home. I've used both terms. I think that's a misunderstanding of what happened in Wuhan. It's not what happened in the other places that successfully controlled their epidemics, and it feels ideological to me rather than smart.
So say more about that, because certainly there's a sort of crude understanding of public health and infectious disease that might inspire people to make calls for isolating people or quarantining entire regions. Why do you think that that ultimately isn't the right solution for public health?
Well, I think we should, especially as cases get under control, well, in the total chaos of having little testing and lots of cases, almost any intervention on individual cases that we know about is just a drop in the bucket because most of the cases are ones we don't know about. So at that chaotic stage, I think the best thing to do is society-wide interventions that don't try to find the cases. And that's what New York figured out as their epidemic got out of control, and that's what a lot of other places figured out as well. Once you get down to a more manageable number of cases, I do think that following up cases, testing them, isolating cases as much as possible, even quarantining their contacts as much as possible is important and is a valuable part of control. But what some have suggested is that needs to be done involuntarily. There was an op-ed in the New York Times yesterday and an article in the Globe and Mail today in Toronto saying that the lesson of Wuhan is that unless you essentially take people from their families against their will, you won't succeed. And I think that's a misunderstanding of Wuhan. It's based on a single study that hasn't been peer reviewed and I think is statistically flawed. And it's a misunderstanding of, it's just not what happened in Korea and Singapore. So I think the evidence that it's necessary is weak at best. And the evidence that it could work in the United States, where frankly people have guns and where people mistrust the police, among other special things about our country, it strikes me as extremely dangerous.
Yeah, and it makes me think back to during the Ebola epidemic in West Africa, and when there was a quarantine in Monrovia of certain urban, densely urban areas, and there was a lot of backlash for that, social backlash, and even people violating the quarantine because there was mistrust of the government. When we think about sort of this just social distancing intervention, I think a lot of us, those of us who feel stir crazy, have one reason to want this to end. Certainly, there are voices in our government, from the political sphere, from the economic sphere, calling for ending this as soon as is possible, as soon as we can. We know from the 1918 flu pandemic that ending these measures too soon can lead to another peak in epidemics. How can we know? For one, are you worried about ending it too soon? Are you worried that that's the trend we're moving in? What kind of evidence do you think we need to know when we should be loosening up some of these measures?
Yeah, I think I am concerned about that, in part because people are right that it is destructive to have these control measures. It's destructive of the economy, it's destructive of education, it's destructive of people's relationships. There are all sorts of very legitimate reasons why people hate this, and the comfortable professional sector is the least affected because people like that can work from home and it doesn't destroy their livelihood. But but people in service industries that are not considered essential are in a very different position. So that's so I want to just start by, or make sure to acknowledge that it's not, nobody sensible thinks that these are good things to do and wants to continue them unnecessarily. The problem is that when the time when it will be safe to let them go is when there's enough immunity in the population so that transmission is going to be under control even without them. And at the moment, so the first priority for finding out where we are along that continuum is to roll out serologic testing. So testing of how many people in the population have had the virus and made immune responses to it. Until we have that, we're all talking in a little bit of a data vacuum. And so in thinking about your original question, what's the best case scenario? Best case scenario would be that we have been missing way more cases than we thought, and that there are lots of people out there who have been infected and have developed an immune response that we just didn't know about.
And how likely do you think that is? I mean, I know we need the serological test to look for antibodies in the population of people who are not coming into emergency rooms and ICU units to know this for sure. But what's your sense of that, the fatality rate? Are we under or overestimating that right now?
Yeah, I think it's clear that, I mean, everybody in my business agrees that in the US, we are not detecting all cases because of lack of testing. And that maybe the true number is 5 or 10 times what we think it is. But that's still a tiny fraction of the US population, and even a small fraction of the populations in the hotspots. So I think there could be, that could be right, it could be in that range, or there could be surprises in both directions. The surprise in the beneficial direction is maybe there are just a lot of very mild cases that we haven't seen, or that preceded when there was any testing to be had, or that we just somehow missed. And I think that is possible. And there are little tiny anecdotal bits of evidence that suggest we are missing maybe more cases than we thought. On the other side, we're assuming that infection leads to immunity, at least for a while. And while that may well be true, there was a paper that came out on a preprint server this morning suggesting that in China, maybe a third of people who had documented infections did not have visible immune responses. So if that were true, then that means that for each infection that we get, there's less immunity in the population than we thought. So how those two kinds of surprises will play out, I think we'll know the first part about how many people have immune responses at all. I'd say in a couple of weeks, we'll have beginning to have a picture. But the second question of whether those immune responses are protective, I think it's going to take longer because it's a much harder study to do.
So, and this, the CDC, the Centers for Disease Control in the US, has announced that they will be doing, to some degree, doing these immunity tests in the population. So when you say a couple of weeks, are those the results you're going to be tracking? Is there some other set of studies that are happening?
Yeah, they are scaling up. I haven't read the details of all the things they're planning to do, but also there are state level plans in many states to do surveillance of various sorts. One idea, for example, is that you can, when a baby is born, they take a drop of blood from the baby's heel to test for a whole bunch of different things, and you can test that blood also for antibodies to COVID if you have a good test. And that will tell you, because the baby gets antibodies from the mother, that will tell you whether the mother had infection. And so that's a way of, kind of creative way of looking at a fairly representative cross-section, at least of the female childbearing age population, that's not super biased by symptoms or access to care or things like that compared to other samples. So I think that's for just an example of one promising way to look at the prevalence of immunity, but it will take multiple studies in different groups to try to triangulate and get an estimate.
Fascinating. So if I'm hearing you right about the best case scenario, it's that we have this kind of picture, we get more immunity testing rolled out, and then there's an idea of how you can pair the intervention, loosen the social distancing accordingly. Say more about what the best case scenario going forward from here in the US looks like.
Yeah, so far when I've been talking about best case, I've been thinking sort of how might the world be that we don't yet know about, but more fortunate than we think. And then the next set of questions about best is whether we can craft a set of interventions that allow the economy to come back while controlling the virus. And I think that's a big challenge. But some ideas that have been discussed are to lighten the social distancing, perhaps by age, with putting fewer restrictions on younger, lower risk people. That has a set of problems, but that's one proposal. Also, if we find that immune responses are protective through studies, then to test people for their immunity and send people back to work who have immunity. Again, that depends on whether immune responses are protective and if we can figure out which ones. And then paired with whatever loosening there is, needs to be a regime of testing and trying to really isolate individuals who are infectious and to the extent possible, follow up their contacts as well. And having said that, I think doing that involuntarily is a terrible idea. I will say, after speaking with colleagues, especially from more densely populated places, making the option available to people to get out of their homes, if that home is say a very small place, and into a hotel room or some other kind of a setting where they can isolate themselves comfortably and humanely, but doing that as an option rather than as a mandate, I think is an important thing to have, because there are people who really can't isolate themselves from their family members, for example, at home. So that's one thing. And then the last thing I would say is there's a lot of work being done, especially in Europe, but also in the United States, on sort of trying to do electronic contact tracing through cell phones. The idea of that would be that through low energy Bluetooth, you can tell if people have been very close to one another, and then link that to information about who gets confirmed as a case, and then notify their contacts. The obvious concerns there are about privacy and data, privacy basically, but there is a lot of work being done to try to address those concerns while also making it possible. I haven't formed a strong opinion, but I think that may be part of the solution.
One thing you've suggested in some of your writing is a sort of contraction and expansion, and a notion that if you really wanted a scientifically sound approach to this, you would leave the option open to basically contract and expand the amount of social mingling we can all do, as the data show, either what we are seeing about the scope of an epidemic or an outbreak in a given place, or what we're learning about immunity. Can you say more about how that would work? And my worry or real skepticism about that question is just sort of, how do you do that in a politically pragmatic way? Is that the kind of thing that can be accomplished with the buy-in of the public?
Yeah. Well, so we're in the process of revising that work for I hope, publication, and we've been a little bit, I think, misrepresented about what we're saying in that work. We're not saying that we think that's the best solution. I think we're saying that is a solution, that it's better than a one-time social distancing and then let it go, because then you have a big epidemic with all the people who haven't been infected yet. But that it's painful and it's politically complicated, and we would probably miscalibrate it sometimes and have the worst case where we both have economic damage and also overwhelm the healthcare system. So it's got many challenges. But the idea of it is that you might be able to, that at some point, due to fatigue or a more scientifically based sense that cases are under control, we might begin to let up, and then we need to keep the possibility open that we would reintroduce distancing as case numbers jumped up. Again, I think it's a very challenging thing for the reasons you say, but I think it's important to see this as a long-term process, and how we play that out. There are many options, and that's one of them.
I want to ask you something about the global picture, because in describing the U.S., one thing that you've said is that, we're only as good really as our weakest links in the chain in terms of our healthcare system. So if we have a bunch of weak rural hospitals and capacities, we could be reigniting this outbreak in various places. And it seems to me that's also true globally. And yesterday at the White House press conference, the president talked about or made a sort of a threat to withdraw U.S. funding from the World Health Organization, based on what I think he took as a criticism that the World Health Organization in general early on said that the policy of instituting travel bans is not the most effective way to address this kind of global outbreak because of the nature of global movement and trade. And so I'm curious, from your point of view, what's at stake? What are the implications of the United States potentially withdrawing that funding at this point in time, both for other countries, but even for our own sake?
Well, I'll start by saying that on that particular point, every colleague I know of in my field said the exact same thing as the World Health Organization. I actually was more sympathetic than any of my colleagues and began to doubt myself because I couldn't find any of them who agreed with me. I thought the travel restrictions were probably a good idea as a piece of a policy that was buying time to try to ramp up all the countermeasures we needed. What we did instead was to have a travel ban as political theater and not do any of the ramping up of countermeasures. So it was completely wasted. And now I now I understand the criticism better. But I think travel restrictions have their place, but it was a very, very popular opinion that the World Health Organization had. It was not just them. Putting that aside, this is a global problem, and the World Health Organization has its huge advantages and its some downsides, like every large organization. But it is what we have. It is the global health organization, and to do anything other than try to help it in a time of global pandemic is irresponsible. I mean, that is what we have, and the rest of the world, especially the less developed countries, are going to have a much worse experience of this than we are, and undermining one of the few organizations that's there to try to mitigate that is a really bad idea.
I want to turn to some of our reader questions that were sent in advance. So Maureen, one of our audience members, asked about the mutation of the virus. She wants to know, by the time we get that hoped for first vaccine, will the virus likely have mutated, making the vaccine less efficacious?
I think that is something that needs to be watched very carefully, and there are a lot of people now studying the evolution of this virus more intently than ever before for any coronavirus. Unfortunately, coronaviruses have been a bit of an obscure corner of the virus world for too long, only partially rescued by SARS and MERS. So we don't have a great understanding of how these viruses evolve. From what I understand, they are not quite in the same category as flu, where really they do evolve around our vaccines every few years. I mean, we haven't had a vaccine, but it doesn't seem that their main mechanism of persistence is to get around our immune systems. It's instead that the immune response is just not that great. So I think that evolution is not, and mutation it will happen. The virus changes almost every time it replicates, but not. But I don't know that that's going to be the biggest challenge. I think the biggest challenge is going to be getting an effective vaccine in the first place.
Good to know. And we have another audience member question named Alex. His name is Alex, and he says, I'm with a small business applying research in machine learning and AI to solve hard problems. As an expert in epidemiology and public health, what role do you see, Marc, in this kind of technology and AI and machine learning playing to solve and mitigate the COVID-19 pandemic?
Great question. I think there are a number of things that have been tried. In China, the company Tencent that does telecoms, they're put together a whole load of materials available on people's phones to help them figure out whether they were possibly sick with COVID. They did an AI chatbot that would help them figure out that question and what they needed to do. If they needed to go for medical treatment, it would pop up with a list of places to go. So there's sort of information dissemination and sort of helping individuals to understand their situation, which has been, I think, less tried in this country. Then there's also in China and in other places, to some extent, this sort of system of indicating of contact tracing, essentially by electronic means. And I think, as I said, I think that may become more common in Europe, and the efforts in this country may succeed as well. I've been not answering emails from one of those efforts, not because I don't want to, but just because I haven't had time. I think they're quite far along technically, and I would really like to learn more about what they can accomplish. So I think those are two areas, and then there may be others in terms of testing drugs and other types of things, but those are the two that I can think of.
Great. I want to turn to some of our live audience questions in a moment, and I'll ask Chris and Mary to chime in with some of the best ones they're seeing. But I guess that really made me think of a personal question I have for you, Marc, which is, here we are in a disaster. It's sort of the equivalent of being on a plane forever interminably with people asking if there's a doctor to treat someone having a heart attack. For you as an epidemiologist, as one of the world's leading epidemiologists, I can imagine, you're being asked to solve a lot of problems, asked to do a lot. How are you managing that with also just our new reality of being socially distant, of having sort of less human connection with people in one way, but lots of demand for your expertise?
Chaotically is probably the one word answer. Yes, I have never been busier or felt more torn in different directions to try to be useful, and also try to maintain some good sleeping, eating, and exercising habits, which are necessary to doing anything else. Yeah, it's nothing like anything I've ever experienced. What I've been trying to do is to be strategic and think about where something that I can contribute is more unusual than what any of 100 other people could do better. And that helps me to avoid certain things where it's just not at the center of my expertise, or there are lots of other people. And that's the most positive thing, is that just the enormous number of people who have stepped up and volunteered their time, their expertise, their money, their strategic thinking. And I think one of the things that's most exciting is to sort of watch that happen and see how many grassroots solutions there are. And then at the same time, sort of lament the fact that because our national government response is so disorganized, a lot of that energy is getting dissipated by duplication or people working at cross purposes, and the lack of really strategic direction from from our national government is disappointing to me. But having said that, I feel as though there's a lot that our Center for Communicable Disease Dynamics can do about sort of we sounded the alarm early. We worked on travelers as a first issue because we thought that people were probably missing a lot of introduced cases. We've been trying to model different scenarios for social distancing. We did the analysis of Wuhan very early to try to make an early warning to people about the consequences of delay. So we've been trying to think of what are the most strategically valuable things we can do. And sometimes we do that on purpose, and sometimes we do it by good luck, and sometimes we miss the mark, but that's been our approach. It helps to have a really great team of about 36 scientists within our center and associated with it who are really expert in a whole range of things, from serology to genetics to modeling and all the other sorts of things we do.
Sounds like a lot of triage. All right, so I'm going to ask Chris to let us know what's on the mind of our audience here, so we can make sure we're busting through the fourth wall and hearing what's on the other side.
Sure. Yeah. And first, I just want to quickly say thanks to the literally hundreds of attendees who've submitted questions. So impressive, your thoughtfulness, your level of engagement. Thank you. And for you, Professor, there's a large number of people who want to express thanks to you for your time, for your thoughts, and for your work right now. So just wanted you to hear that before we got into questions. This one comes from Irene B. Do we have a sense of how long immunity might last for those who have been infected and recovered?
Not yet a well-founded sense, but we have analogies. So from some of the more common seasonal coronaviruses, it looks like there was a study where volunteers were given that coronavirus as a deliberate inoculation, and then they were given the same virus from the freezer a year later, and were protected partially. They were much less likely to get sick the second time. They produced much less virus the second time that could infect others potentially. So we know from that one that the duration of immunity is of effective immunity is close to a year, and maybe a bit longer. We don't know. It wasn't done again 2 years or 3 years. In terms of and then with SARS, the original SARS of 2003, there's evidence that antibodies last for several years at high enough concentrations to be likely protective. But there's no, other than that one human challenge study, there's no direct evidence of how good or how long-lasting immunity is in other coronaviruses, and of course there's not yet evidence in this one. One of the things we've been trying to do is design studies that can look at that. It's really challenging because the people who have immunity are probably under different kinds of exposure than people who don't have immunity, and so trying to essentially treat what's a non-experimental study and make it as much like a randomized trial where you can compare the people in the two different arms because they're the same apart from whether they have immunity. That's a real challenge. And that's what epidemiologists are good at doing, but this is an unusually hard one, and we have the biggest guns working on it who have thought harder about these kinds of questions than anybody else.
That's great. Thank you. Here's another one from Ian H. What treatment options are you most encouraged about?
To be honest, this is not my area, and one of the kinds of triage I've done is to try to pay attention carefully to some things and not spend time on others. So I think I'm going to leave that to others to comment on. I think there's no drug that is just obviously a slam dunk. Remdesivir is only intravenous, and so it's harder to give. Lopinavir, ritonavir is the one trial published was not positive, although I think it could be potentially useful in milder cases. And one thing I have been writing about recently is the need to test all of the drugs that are, at least the oral drugs, in milder cases to see if they can prevent progression, because that's what, for example, the flu drugs work much better if you give them early in infection than if you wait till people are really sick. So I think it would be unfortunate to give up early on the drugs that have only been tried in very sick people, because those are people who've had it for a long time. But as I say, it's really not something where I have deep knowledge of the individual drugs.
Got it. Thank you. This one's a little bit different, from Tiffany O. I've seen a small but growing number of reports of animals catching COVID-19 from humans. Should we be bracing ourselves for a change in relationships with our pets as the virus continues to spread and mutate?
I think it is a concern. I think it's not, I mean, I have 2 dogs and love the dogs, but I don't think that that's at the top of my list of concerns, in the sense that if it really adapts to pets, it may be a problem for pets, but it's then likely not to be the same risk to us. So I think this could be wrong, but I think that's not up there on the list of top concern.
Sure. And then I'll ask one more. This one's from Jenna K. Do you have any thoughts on what we can do now to prepare for a potential second or later wave?
As a society, I think what we need to be doing is accelerating all of these efforts to steel ourselves, which is producing protective equipment, producing swabs and testing kits, producing ventilators, all of those kinds of things. And as I said before, the biggest shame would be to waste the time that we've bought at a very high price of social distancing, and not use every minute of it to build up our resilience as a society. As individuals, I think the main thing would be to find ways to, I mean, if as individuals in relatively privileged positions, to find ways to lighten the blow of further social distancing and further virus spread on those who are in more vulnerable positions. So trying to help elderly relatives make sure that they have a way to get what they need, and to also be less socially isolated. So very early on, I was asked, should I go to a family reunion that my grandparents really want to have? And I said, one person should go to that family reunion and spend the time setting them up with technology so that they can see all their family later. So I think building those kinds of resilience, building educational resilience and all these other things, so that the burden is less, to me, is the most constructive thing we can do.
Thank you so much.
Thank you, Chris. Thanks so much for bringing in those questions. And I apologize to all of the people whose questions did not get answered. I just wanted to ask a sort of final closing question to you, Marc. Are there any lessons we can learn from historic outbreaks, from historic epidemics, about sort of how life returns to normal after this one?
Yeah, I mean, I think the most important thing to learn is that life does return to normal. And this is not the plague that ravaged Europe and really depopulated Europe. This is not that kind of severity, and we will get through it. It's much more in the sort of realm of 1918, which, you know, in one sense, as I was saying to my kids last night, who were beginning to realize how complicated a situation we're in, you know, in one sense, 1918 was the public health event of the 20th century, with the possible exception of HIV later in the century, different kind of event, and you know, was incredibly destructive. On the other hand, you know, the vast majority of people got through it My grandfather was born in the middle of it, and had his daughter who had me. So there are. It feels very, very intense right now, and it is very, very intense. But there will be an end to it. It's not going to be a decade-long debacle. It's going to be, hopefully, in a year or two, we will feel like we're on the other side of it, and it's important to keep hope that that's the case. In the meanwhile, there's going to be a lot of challenges of all sorts, and trying to keep some social solidarity so that it doesn't rip our society further apart, I think is really critical.
Thank you so much for that note of optimism, and also for the call to all of us to be our best selves in this time. And thank you so much for your time, Dr. Marc Lipsitch. We know how precious it is and how important it is, and we're really grateful that you would take the time to educate our readers and this audience. I want to thank everyone for joining us for this Globe Op Talk. As I mentioned, this is an experiment we're trying at Globe Opinion and Globe Ideas, and we'd love your feedback on how this was for you, as well as for you to tune in again. We'll have another one probably next week. Thank you so much.
Thank you.
Thanks, everyone.